biliary system, for our part, and what we need to know about the biliary system is, consists of the liver and all the ducting and the gallbladder, and then, we add in the pancreas. So there are a lot of different things that the liver does. They've identified like 1,000 of them. For our purposes, really it's just about bile. So what we've got in the liver, of course, we've got two lobes. The left lobe is significantly larger than the right lobe, and it's divided by what we refer to as the falciform ligament. So falciform ligament, anybody know what that attaches to still to this day, unless you've had some sort of surgery where they went through, big hint, belly button? It's where your umbilical cord used to plug in. All right, so it's a fetal remnant of that. So what you've got is you've got the left lobe. The left lobe is significantly smaller than the right lobe. Whenever they do a liver transplant, that's what they take. All right, so what we've got in the liver is you've got what we refer to as biliary tree on both sides of this ligament. All right, so what we'll have then is all of these will join up together to create what we refer to as the right common duct. Okay, it's common duct because, all the other bile ducts join together to create that one duct. The ones on this other side will join together with and also create the left common duct. All right, so they join up together, and then that creates, when they both come together, that creates the common hepatic duct. Okay, so we're still missing a couple of things. One, see if I got a balloon marker. Yeah. First time you go to surgery and you see a gallbladder removed, you'll know the gallbladder when you see it because it's blue. All right, so blue. So you got your gallbladder, it's kind of back behind the liver, and it's also got a duct that comes out of it. And it's not round like that, but it comes out and it joins up with the common hepatic duct. Let's point up here for the common hepatic. And at this point, it becomes what we refer to as the common bile duct. Okay, so where all the little ducting comes together for the left side, that's common, left common. Right common is where all the little ones come together. Where all of them come together, all the small biliary ducting comes together, that's going to be your common hepatic. Joins up to the cystic duct, what we refer to as a cystic duct. Cyst just means sac, so cystic duct, and creates what we refer to as common bile duct. Okay, so this is going to come down, and it's going to, it doesn't exactly come down this far, but it's going to come down, it's going to join up to the duct that comes out of the pancreas. That pancreatic duct is what we refer to as the duct of Wirsung, W-I-R-S-U-N-G. Okay, so all that stuff comes together and it opens up into the small intestine. First off, where the two join together, it's kind of like where highways come together and the lanes get wider, right? That's an enlarged area so traffic can flow, right? Well, the same thing happens right here, and where we call expanded areas where you get more water flow or whatever is an ampulla. Okay, and it's ampulla vater, not V-A-D-E-R for you Star Wars people. It's V-A-T-E-R, ampulla vater. And then at the point where it empties into the small intestine, that's what we refer to as the sphincter of Oddi, O-D-I. And again, if we have a stone, the sphincter is, just as it suggests, a sphincter, it's got a muscular thing around it, and it can open and close. So it opens up to allow bile in to the small intestine, so you can digest the fatty foods, and then it closes back up. So it's not just a big hole that dumps bile into the small intestine at all times. If it was, then we wouldn't have a problem with gallstones, pretty much sticking right there, right? So again, what we'll do is, if I get rid of some of this traffic up in here so that you can see the gallbladder all by itself a little bit better. What they'll do in surgery is, if the patient has a history of gallstones just don't go away. And what will happen is the expanded upper end will kind of accept the stone into it, and then bile will wash it back into the gallbladder. And it'll go back and forth, it'll build up, and it'll get larger and larger to the point where it can't pass. Some patients will develop a gallstone that'll pass it, but if it gets big enough, it just won't pass. And then we've got to go in and get it, either with a basket, ERCP, or possibly remove the gallbladder. If they remove the gallbladder, let's just draw it separately. Gallbladder, you got that neck, and then you got the tapered end that comes out like that. So what they'll do is, whenever they remove gallbladder, is they will clamp it off, okay? Because bile is, it digests fat. So if that leaks, too much of that leaks into your peritoneum, what do you got? Your body's trying to eat itself, right? And it's not a good thing, right? So they don't want to just cut this thing out and remove it, because all that bile leaks in. They want to minimize that. So they'll clamp it off. They'll put a staple across it, and they'll cut a little bitty slit into it, and then they will take and put the catheter down into it to inject the contrast. So what they'll do is they'll inject the contrast, and like I was showing you before, what we're looking for is absence of filling to determine whether or not the patient has a stone. And if they inject contrast and they don't see any evidence of a stone, they'll go ahead and they'll clip it again. No, they'll clip that first before they inject the contrast, so it doesn't just come right back out. But what they'll do is they'll probably put a couple more staples into it, and they'll remove, they'll cut the gallbladder all the way away, and they'll remove the gallbladder. If there's still a stone there, then what they'll do is they'll feed a T-tube into it and let it decompress, and hopefully the T-tube will allow the stone to come back up through the T-tube, decompress, and they can pull the T-tube. The duct heals up and the patient goes home. Hopefully the duct heals up and the patient goes home. Had a neighbor one time, years and years ago, that he had his gallbladder removed, and the ducting did not heal up very well, and he got really, really sick, and he was only 35 years old. Like that killed him. So, there are potential complications to that. Now, if they do all that and they still have a problem, then they can do what we refer to as a common bile duct exploration. So before they put the T-tube into the patient, sometimes they'll take a small scope and they'll go down into the common bile duct and look for the stone, see if they can pull it out that way. Re-inject the contrast if they can't get it, and then they'll put the T-tube in. Okay? So complications for, indications for any kind of cholangiogram, usually kidney stone, or usually gallstone. All right, there is one other duct that you need to be aware of. Sometimes the pancreas will have an accessory duct. So you don't know about this thing, it's an incidental finding. And what they'll do is, especially on an ERCP, you go to inject, and what you'll see is a secondary duct that comes off of the primary duct, and the patient has two pancreatic ducts. All right, and that's what we refer to as a duct of Santorini. All right, so everybody's seen the probably one of the more popular pictures of an island in Greece where you got these stark white buildings with blue roofs. That's Santorini. Okay, so ductus Santorini. Just word association. Ductus Santorini is an accessory pancreatic duct. Duct of Wiersong is, it's just pancreatic duct. Now, ductus Santorini can extend all the way to the duodenum where you've got two different insertions into it. They'll probably be able to visualize that on the ERCP, but if they inject into the duct of Wiersong, they're not going to see the ductus Santorini that way. They would have to inject them separately. Okay? So any questions on the biliary system and anatomy, exam types, things that we do with that? Okay, then let's shift gears. And before I bring that back up, we'll talk about the anatomy of the urinary system. So urinary system, you got two kidneys. Most people have two kidneys. Two ureters. Those are the tubes that go from the kidneys down to the bladder. One bladder, and there's variations of all that. All right, so generally speaking, the right kidney is a little bit lower than the left kidney because of the placement of the liver. Exactly, the liver being the largest single solid organ in the body. Area-wise, I give that to the lungs, but solid organ, you collapse a lung down to that. So single largest solid organ would be the liver. All right, so didn't really draw those, left one any higher than the right one. But what you've got in the kidneys is obviously a kidney bean-shaped organ. And what it's got is it's got a lot of stuff that goes into this area right here, okay? So now let's think back to last semester in the lungs, where we had a lot of traffic that goes into and out of the lungs. You had the bronchus, you had the pulmonary arteries, pulmonary veins. What did we call that region? Hilum, right, it's hilum. So this is going to be the hilum of the kidneys, all right? So you got kind of the same thing, only instead of air, you've got urine. So think of the kidneys as being specifically positioned to where they're kind of like a tea kettle that's kind of, tipped a little bit. So they're positioned in the body so that the urine, is kind of pouring down into the ureters. Most of the pathologies we're going to be looking for in radiology, again, are going to be stones, kidney stones in this case. So what we've got in the kidneys is a collecting system where the urine, the nephron, is a functional portion of the kidney, but the urine is going to collect in the kidney and then pass into the ureter. So our collecting system is that's pretty decent. They're this is a long kidney, man. Kind of shaped like this, all right? And what we refer to these things as are calyces, okay? So each one of these is a calyx. So collecting system, the nephrons are up in here, they're creating the urine, they're pushing it down into the collecting system. Where you have one calyx, minor calyx, you've got one calyx in a minor calyx. Collection of calyces, we've got a major calyx. So what we do is we create the urine and it passes through the, hopefully, it'll pass through the ureter all the way down, take some turns, and plugs into kind of the posterior inferior portion of the bladder. All right, that's going to have a significance here in a bit. And much like the kidneys, or much like the biliary system, everything works well until you get something that obstructs it. So most of the time, it's going to be a kidney stone. Sometimes it's a baby. So moms, I know we talked about bowel obstructions last time, an ileus. Well, happy birthday, you got another thing to worry about. Baby sitting on your ureter, and you essentially can't pass urine out of one kidney or the other. So when we have any kind of obstruction, what'll happen is the kidney will swell. You'll see this on the image as what we refer to as hydronephrosis. Okay, osis, medical terminology, what does osis mean? Condition of, is that what you said? Yeah, condition of. Okay, hydro, what is hydro? Water. Neph is always going to refer to the kidneys, right? So hydronephrosis. And it seems like it's, you've always got hydronephrosis. The purpose for the kidneys is to make water, right? Well, it's the condition of where you got too much water on the kidney and it swells and it gets big, okay? So the exam types that we used to do for kidney stones were what we referred to as IVP, okay? IVP stands for intravenous polygram. Okay, so we can't leave it at that and make it simple. It's also referred to as an antegrade polygram because we're going to go with the flow, and I'll explain that here in a bit. So it could be antegrade. Could be antegrade nephrography. That doesn't roll off the tongue. And it could be also EXU, excretory urogram, okay? All three of those mean exactly the same thing. So what we do with an IVP, and I'm just going to use IVP because that's most common in my experience, terminology, is that we're going to inject the patient with contrast and watch it as it flows from the kidneys to the bladder. It's usually a short exam. Don't do a whole lot of them. Do y'all see these in clinicals anymore? Because it there's an ebb and flow to it. Sometimes we'll do them, and then all the radiologists want every patient who has a potential kidney stone to go to CT, and then 2 years later we're doing a lot of IVPs. So don't be surprised if these come back around. They're easy exams, and they were great for first semester students because you could nail KUBs, in one rotation through an IVP room, because that's all you do is IVPs. And IVP is KUBs, pretty much. So what we would do is we would do a scout image. A scout is just a KUB. See where the kidneys were, see what the kidneys looked like, make sure that you had your centering proper, see if there were any surprises. Sometimes your patient is not real forthcoming with their medical history. And as such, they might not tell you, well, I have, I had a kidney replaced, let's say. Well, if they replace a kidney, they're not going to put the kidney back up here because then they got to thread the ureter all the way back, down into the bladder. So if they replace a kidney, what they'll do is they'll put the kidney down in the pelvic cavity and they'll point it so that it drains directly into the bladder. Okay, that's need to know information, right? So, sometimes patients won't tell you that. Sometimes they won't tell you that they got a kidney out of place. Sometimes, a patient will have, a kidney way down here. So we do the scout, and then what we would do is we would draw up 2 of the ISAView 50 cc ISAView, and we'd take the scout back to the radiologist, and we'd have the radiologist take a look at it. They'd tell us what they wanted, just normal routine most of the time. So what we would do is inject the patient and take a film immediately. All right, so that would be what we would refer to as a 0 minute. So we shoot the scout, show the rad, inject, and shoot an immediate image. That's what we refer to as a 0 minute. With a 0 minute, the urine, blood circulates through the body about every minute, right? So at a 0 minute, the urine or all the contrast is going to be up in the kidneys. So can you spot the kidneys on a KUB yet? Can you see them pretty well? It's a lot easier with digital than what it used to be with screens and films, but in a lot of cases you don't see the top of the kidneys, right, on a KUB. You see that much of them. So on the 0 minute, what we would do is intentionally center high to make sure we get the top of the kidneys. And then we'll get that blush just in the kidneys themselves. We see all the contrast in the kidneys. After the 0 minute, we would shoot a 5 minute. So 5 minute, we shoot like KUB. We start to see the contrast coming down. Some is probably going to be in the bladder, but we're going to be able to visualize it in the ureters. And then most of the time we do a 10 minute, a 15 minute with obliques. Okay, and obliques had a specific purpose. Your kidneys, they're not, in the patient's body just straight up and down. It's kind of like what you see with the stomach. They've got they're just not straight up and down. So when you're shooting a KUB, you're shooting a distorted view of the kidneys. Okay, so they're really kind of in the body, upper pole a little bit posterior, and they're also obliqued outwardly a little bit. Okay, so they're like this. So we do bilateral obliques, and again, we might want to center a little bit high to make sure that we get the entire kidney. And what we would do is oblique the patient about 30 to 45 degrees. And what that would do is it would take the upside kidney and put it pretty much perpendicular to the central ray. All right, so now we truly have a frontal view of the kidney, right? But the kidney closest to the image receptor is more like lateral. Does that make sense? So we do bilateral obliques, meaning we do LPO and RPO to get both of those views of all of it. If everything is flowing well, then we do what we refer to as a post void. All right, so we get the patient up, take them to the restroom, let them use the restroom, bring them back, shoot one more image with their bladder empty. And some radiologists like for us to do them upright, just to see if there's any kind of bladder prolapse or anything like that. Some radiologists, because kind of like in the biliary system, sometimes the stones would stick way down here, right, at the urethral insert. And so what some of our radiologists would like us to do is angle 15 degrees posteriorly to kind of come over the top of the bladder to see more of the distal portion of the ureter. Also though, on those obliques, if you don't center too high, you can also see the distal portion of the ureters as well, where they plug in. So if there's a kidney stone there or some sort of pathology or some sort of variation, then like you can have what we refer to as a ureterocele, which is kind of like a prolapse of the ureter into the bladder. So it has a specific appearance to it. It kind of looks like a donut artifact inside the bladder itself. Okay. So again, scout, inject, 0 minute, 5 minutes, 10 minutes, 15 minute, post void, maybe upright, maybe 15 minute with obliques, post void, maybe upright, maybe a caudal angulation. That's generally your IVP. Okay. May never shoot one. We may go, through the rest of your career with everybody going to CT, still on registry. Okay. So a couple of things that you need to ask the patient You need to get their history. Do they have a history of kidney stone? I'd say probably the most common precursor to kidney stones would be the family history. You know, I'm a salt junkie. Never had a kidney stone. Other people have, you know, they completely eliminate salt from their diet and just make them all the time. Little kids have them, right? So it's a family thing in most cases. Most common thing that we're going to be looking for is an obstruction. Most common obstruction is going to be your kidney stone. So sometimes, though, you know, I've seen this happen. We've got a pregnant patient, and you know, far enough into pregnancy, the baby's getting kind of big, and they want to see if, you know, the baby's sitting on a ureter. So they'll do a limited study IVP. Why limited study?
So the baby's not subjected to as much radiation?
Right, right. As whole body dose on every image you shoot. Okay, so we were talking about this last Wednesday. What kind of techniques are better for radiation dose to the patient? High KVP, low mass, exactly. So what we would do in that case is limited study would increase our KVP somewhat and reduce our mass in order to you know, limit the dose to the baby. Now, what I did not mention on Wednesday, okay, and this is testable for the next test in imaging, so shift gears just a little bit. Yeah, I know. Shift gears just a little bit, but it's applicable here, and it plugs into this. All right, so what mass do you usually set for KV? It's a trick question. Huh? Somebody said it, I think.
You don't.
You don't. Right, what are you doing? Phototimer. Right, phototimer. So, how do phototimers work? I need dipping back into last semester. How do phototimers work? Just counts the radiation, right? Just counts the radiation. What does KVP give you? What does it control? Penetration. So as you increase your KVP, you get more penetration, right? You get more penetration. So if you're phototiming, okay, and again, this, don't miss this on the test. If you want to reduce the dose to the patient, right? You want to reduce the dose to the patient. You know you got a pregnant patient. You increase KVP and reduce mass. If you're phototiming, what do? You increase KVP and the machine lowers your mass. Okay? All right? So all you do is increase KVP and the machine's going to take care of it. All right? So make sure you pay attention to the question. You know, if you want to reduce dose to the patient while you're phototiming, what do? Increase KVP. Yeah. Somebody's going to ask, well, if I increase KVP, that's going to increase dose, because if you just increase KVP, you just increase dose. Yes, but you're phototiming. The phototimer is going to reduce your mass. And it's going to reduce exposure to the patient. Okay, don't miss that on the test. Okay, so what other type of exams do we do for the urinary system? Well, glad you asked. Okay, so this is all total urinary system. That is not. All right, so sometimes we have to do cystogram, just a study of the bladder itself. And most of the time, those are going to be traumatic. Sometimes you'll do cystograms in surgery. We're not really going to go through that all that much. They'll do there's a box in the Merrills. If we don't get back to the PowerPoints, there's a box in the Merrills. Kind of breaks down what the different prefixes mean. Pylo means the renal pelvis, where the ureters come directly out of the kidneys. So make sure that you look through that. So sometimes we'll do a retrograde pyelogram in surgery and whatnot, but what we're going to focus on is what you might actually do. So sometimes a patient gets in a trauma, gets in a car wreck, and they've got a full bladder. And imagine that you've got a water balloon, and you've grabbed the water balloon by the stem where you put the water in, right? And let's say you take the water balloon in your hand, you hold onto that very firmly, and you move your hand real fast, and then you stop. What happens? What's going to happen with a water balloon?
It's gonna pop.
It's going to pop. It's going to pop. Okay, so imagine that happening at your urethra. Okay, it happens. So people get in a high-speed collision, and what will happen sometimes is their urethra will sever from the bladder. Sometimes you get a total bladder rupture. Sometimes it accompanies pelvic fractures. And sometimes what we'll have to do is a cystogram in the emergency room. So the type of contrast that we're going to inject the patient with is going to be non-ionic. All right, so your isoviews, things like that. Isoview is a brand name, but it's non-ionic. So the chances of reaction are low in non-ionic because the body just doesn't recognize it quite as well as iodine as what it otherwise would. All right, but if we're just injecting into the bladder, then in the bladder, it's not going in the bloodstream. Chances of reaction are low still. Patient can still react. If they're allergic to iodine, you need to ask them that. You need to ask IVP patients, are you allergic to iodine? Are you diabetic? And if you're diabetic, what kind of medication are you taking? Okay. Also ask them if they're hypertensive, because if they have very high blood pressure and suddenly you increase their blood volume by 100 cc's, that could be bad, right? I'll tell you a story about that if we have time here in a bit. But anyway, if you're just injecting into the bladder, you got a little bit more leniency, right? So what happens with ureteral rupture is that they'll try to pass a catheter and they hit a roadblock. It just doesn't go in. So what they'll want to do is take like a cath tip syringe and inject and see if it goes into the bladder. And we'll take an x-ray if it does. If it seems to go into the bladder, or they can get some sort of injection, it might just be leaking out into the peritoneum. So we'll take an x-ray to see what's going on. Is the bladder ruptured? Is the urethra ruptured? Exactly what's going on there. So that's a cystogram. A cystogram usually comes with like a bladder shot. Just put the top of the image receptor, your collimated field, at the ASIS, open it up enough to get to the symphysis pubis. And we'll usually do an AP and 2 30-degree obliques. Again, we're just looking for the contour of the bladder. Is it ruptured? Another exam that we do is what we refer to as a voiding cystourethrogram, or a VCUG. VCUG. Voiding cystourethrogram. Demographics for VCUG are very specific. The indications are, consistent urinary tract infections, especially kidney infections. All right, so we got the kidney infections, kids having them all the time. Also, the kid is not necessarily malnourished, but they're just not growing at the rate that they should. That's what we refer to as failure to thrive. Almost always little girls, 5 years old and younger, little bitty things, constant urinary tract infections. Okay? Now, I'm just going to say it. I've never done one of these. I've never been considered to do one of these things. The only time a guy is likely to do one of these in East Texas is if you are the only person on the shift. Okay? And you need to be okay with that. because here's the demographic. Again, it's little girls, 5 years younger. Their mom's going to be there. Their dad's going to be there. The kid is just absolutely miserable, okay? And this is what we're going to do. It's voiding cystourethrogram. So what we're going to do is we're going to fill their bladder up with contrast, and we're going to watch as they urinate. Okay, so how are you going to fill the bladder up? All by itself.
Catheter?
Catheter, right. Catheter. So you're going to take this 5-year-old kid, and what have you been telling this 5-year-old kid for their entire, well, for 3 of their 5 years?
Don't pee your pants.
What's that?
Don't pee your pants.
Don't pee your pants. Don't let anybody see it. Don't let anybody touch it. Right? Don't talk to strangers.
Stranger danger.
Yeah, stranger danger. And there's something else. But anyway, you're going to bring them in, and what are you going to have to do?
Violate all of those rules.
Every one of those things. Every single, in front of mom, who's probably going to be more hysterical than the kid. Now, Nixon, I'm going to pick on you a little bit. Do you want a monster like this? Or you want a delicate little lady with your baby girl? Yeah, exactly. Exactly.
What do you want?
Yeah.
Yeah.
And if you were a 5-year-old girl, what would you want? They don't want to see me, you know. They don't want to see anybody, but especially don't want to see me, right? So you got guys, you got to be okay with this. You know, don't get offended that, you know, I want to do. No, you don't. Just, you know, go find your chest X-ray or something to do. So what we're going to do with this is we're going to fill the bladder up. They're going to put a catheter into this poor little kid. They're going to fill the bladder up. They're going to pull the catheter out, fluoro, and say, okay, pee all over yourself. And what we're going to be looking for is reflux going up into the kidneys. VCUG, voiding cystourethrogram, we're looking for reflux going from the bladder up into the kidneys. Okay? Look and see if I missed anything. It may be a little early. Come on. Okay, so education provided. Yeah. Oh, yeah. So if you ever do a IVP, or if you find yourself working in CT, where they do a lot of contrast exams, you might add to your patient information that once you inject the contrast, they may feel a little bit of a speeding up of the heart rate, right? So they may feel a little bit of a fluttery type thing in their chest, and it kind of feels like they might have urinated on themselves a little bit. They get a warm flash of warm feeling, in that area. So you might want to let them know that that's coming. Because if you're laying there on the table and somebody said, well, people die from the x-ray dye that they put into you, and the first thing they feel is that flutter in their heart, they can have what we refer to as a placebo effect. They think they're dying, and the study is pretty much over at that point. So somebody should have gotten an informed consent from them already. So that they should have gone through the complications, but you might want to explain that to them and say that that's not a complication, that's normal, right? All right, so patient assessment, ask them about food allergies, medication allergies. Medication allergies more important than food allergies. You might ask them if they use regular salt or if they have to get, special salt, sea salt. And some people will tell you that allergies to iodine really don't matter in the history for injectable contrast, and I'm going to tell you it does. We had a biomed guy over at ETMC, is now UT, that he couldn't touch a bottle. If he walked into the room, there was a bottle of contrast on the, whatever it was he was working on, he'd walk back out of the room, he'd say, somebody needs to come move that and clean off my work area. He'd have a reaction. And that was non-ionic contrast. He couldn't touch it because he was so allergic to iodine. So it's still valid. Whether or not they're allergic to strawberries may or may not have any impact. But what medications are you allergic to, and are you allergic to iodine? Very important. Diabetes, certain medications, diabetic medications can cause negative reactions as well. So venipuncture, that's what y'all are going to be doing in the lab this week. Make sure that you use your alcohol wipes and all that. Okay. So this is a commonly missed question on the test. The larger the diameter of the needle, the smaller the number. It's kind of like shotguns. This is Texas. You don't know about shotguns? What's a 12 gauge versus a 20 gauge? 12 gauge is bigger, right? So the smaller the number, the bigger the hole, all right? So when we're talking about the bore of a needle, the bigger the number, the smaller the needle, right? Okay. So how that plays a part is that you want to use the smallest needle for patient comfort, but you don't want to use the smallest needle available if you can avoid it. Because if you're doing an IVP and you're trying to inject contrast into the patient, you've got a 24 gauge needle. It's going to take you a long time to get that contrast into the patient. So, 20 gauge is pretty good. Butterflies are great. Syringes, a lot of stuff we don't really need. Reactions. The book goes into different reactions, mild, moderate, severe. Severe being anaphylaxis. Anaphylaxis is extreme, all right? And I never had a patient truly go into anaphylaxis. The worst reaction I ever had was actually a placebo reaction. The patient was a bit of a hypochondriac. She had a kidney stone. They put a lot of water in her, so there was a lot of pressure on her kidney stone. And then they gave her way too much pain medication. So, you get a little high, you get a little paranoid, and then we inject contrast, her heart starts fluttering. She literally thought she was dying. It was a horrible study. So that was actually the worst one I ever had. But mild, they get into moderate and they start talking about respiratory distress. To me, that's severe. How long are you going to live if you can't breathe, right? So the thing is, these can progress. Mild may be itching, moderate may be respiratory distress, and severe is anaphylaxis. But the thing is, it can go from one to the other immediately, and most of your reactions are going to be pretty quick. So, patient says, I'm itchy, nurse, get some Benadryl on board, get some adrenaline available, right? Some epinephrine available, just in case it progresses. So, anyway, mild reaction, sensational warmth, that's not really a reaction. Metallic taste, sneezing. Patient starts sneezing, I'm going to look at them with a little bit of a side eye. Moderate, they're vomiting, I'm getting somebody in the room. And then severe, again, is anaphylaxis. So we talked about all this. Minor calyx, major calyx, collecting system, the medulla, renal pelvis, the hilum.
Will we need to know the order that it goes in? through the kidney?
Not really, but you can, I mean, you kind of work it out. I don't think that there's any question on, are you talking about like nephron to minor to major?
Mhm.
I don't think there's any questions on that. I do have one other thing though. Kidney stones. Kidney stones very common. Less common would be what we refer to as staghorn kidney stone. Okay, so staghorn kidney stone, and you can kind of look at this and you can kind of figure out why they call it a staghorn kidney stone. What's a stag? It's a deer, right? Staghorn kidney stone. It kind of looks like a moose antler, and you turn your head a little bit sideways, right? A staghorn kidney stone is a kidney stone that completely fills up the calyces, completely fills everything up. And most of your kidney stones, they can go in and they can retrieve them with a basket, like what I was talking about before, or they can do what they refer to as electronic shockwave lithotripsy. They just shorten that to SWAL. And that's where they put them in a tub of water and they use sound waves to break up kidney stone. They'll put a stent into the patient's ureter all the way up into the kidney, and it sticks down into the bladder just to keep the keep the ureter open, and they'll just pop it until it breaks up. Staghorn kidney stone, they can't do that with. It's just too big. So they'll do a different type of perk. This is not the perk that we were talking about before, but they'll punch a hole in the patient's back. Kidneys are retroperitoneal. They'll punch a hole in the patient's back and they'll stick this thing inside of it to kind of grind it up and just wash it all out. If you're ever in, and it's done in surgery. And it's not a sterile procedure. It's one of the few things that you'll see. It's a clean procedure, but it's one of the few procedures that you'll see in surgery where this is a urologist, he's not wearing a mask. Just because, you're dealing with so much urine and whatnot, it's just no way to keep it completely sterile, truly sterile. So staghorn kidney stone completely fills all that up, and they got to punch a hole in the kidney to get to it. So you do need to know that the nephron's a functional portion of the kidney. Let's see. Bottom of the bladder, this trigone is a triangular area where all of this is. Okay, so where all the traffic is coming in, you got your ureteral openings and your urethral openings. This is the only portion of the bladder that doesn't really stretch a lot, right? It's pretty, I won't say rigid, but it's not as flexible as the rest of the bladder. Prostate, obviously only men, and the ureter goes through the prostate. Contrast studies, again, reactions, patient preparation. Okay, so patient preparation for like a IVP would be minimum of NPO after midnight. They may ask for like cleansing enemas or something like that, but definitely NPO after midnight. I just want to make sure I didn't miss anything since I didn't have this up at all. Motion control would be, for the most part, just good instructions. Okay, this mouse is kind of touchy. All right. Patient cooperation, hold your breath, right, is pretty much your motion control. We can use ureteral compression. Let me see if we got a good KUB image. Yeah, here we go. Ureteral compression, what we use these for is if we want to slow down the flow of urine from the kidney to the bladder, it's just moving too fast to get a good study, we use ureteral compression. It's important to understand that you don't use compression if you know or suspect the patient has a kidney stone. So what you do is you take this hard plastic plate, you put these two inflatable things, kind of like a blood pressure cuff, only just little pads. You put those under that hard plate and then you put a strap around it. So you inflate these little balloons, and what that does is it pushes the abdominal contents back into the ureter, which then pushes, into the pelvis, And if there's a stone down there, you very well could push it through the ureteral wall. So you don't want to do that. So, you know, if the patient has a stone, those are contraindicated. Another way to apply pressure without using those is to shoot your IVPs prone. Flip the patient around, their body weight pretty much does the same thing. So you may, you know, hear somebody doing that if we ever get back to using IVPs again. So IVP, that's what we're looking for. Kidneys all the way down to the bladder. Understand that kind of like what we talked about last semester, according to the textbook, all of our exams are going to be shot on exhalation, right? But a lot of our doctors want them shot on inhalation so that we can see everything, you know, top of the pole. So again, the textbook answer doesn't always match what you're doing in clinicals. All KUBs are shot on exhalation. Test question. Okay, so every one of them are shot on exhalation, expiration. That's to limit scatter radiation. We'll talk about that later in the semester. All right. Don't do a whole lot of laterals. Decubitus hydronephrosis. Notice we've got plenty of contrast in the kidney, nothing coming down the ureter. Ureterocele, that's what they call a cobra head sign. It's kind of like a prolapse of the ureter. That's a stone. Again, radiolucent. Staghorn kidney stone in a patient with, it looks like pretty severe scoliosis. Bladder stones. I was hoping that I could see, you've got calcified, you may have seen these, but you've got calcified veins, or not veins, calcified ligaments down in your pelvis that appear as perfectly round artifacts. A lot of people will look at those, you know, early on and say, well, it looks like they've got a kidney stone in the distal portion of your ureter. It's not a kidney stone. You don't see them on these, but if you happen to see them on an image in clinicals, it's what we refer to as a phthalate. So weird word. Nephroptosis, again, the reason we shoot a scout is to find where the anatomy is. This patient's got a kidney that's way down here in the pelvis. Also, what you'll find is that some people have an abnormally small kidney. Okay, so overdevelopment, we refer to overdevelopment of something as being, what's the word for it?
Large.
Large? Yeah, large. Now I've lost it. Huh?
Mega?
Well, mega would be extremely. I'll think of it about the time we leave. All right, so sometimes the patient will have a very small kidney. And to compensate for that small kidney, we'll have an overdeveloped kidney. So if a patient has a very, very small kidney on one side, again, we'll hopefully see this in the scout. Have a small kidney on one side, you'll also see a very large kidney on the opposite side. All right. So sometimes you'll see a patient with what we refer to as double collecting systems. And what that is two renal pelvises, and they may have two insertions into the bladder. They may join up somewhere down here distally. Oddly enough, you know, and it seems like an ideal situation. You know, you got a kidney stone stuck in one, you still got another one, right? Well, the problem with the double collecting system, specifically where you have two insertions into the bladder, is that sometimes that second insertion does not have a sphincter. If it doesn't have a sphincter, then you have a natural propensity to have reflux, so increased kidney infections on that side. Okay, if they come together, then you don't have a problem. But if we have separate insertions, sometimes we do. All right, so cystocele is prolapsed bladder. Again, this is part of the reason we do an upright post, maybe even pre-post, post-void. So another exam that they'll do, they do this most of the time in urologist's office now, is that if they suspect the patient has a prolapsed bladder, they may inject contrast directly into in the urologist's office. If the patient has what we refer to as stress incontinence, you know, you cough or you sneeze or exert pressure and you pass a little bit of urine, they may do what they refer to as bead chain radiography. Okay, so bead chain is, you know, the pull chains that you have for lights on and lights off in the closet or whatever. That's a bead chain. So they'll sterilize one of those, put it up into the ureter, and pull and see if there's leakage, you know, as it comes out. So that's bead chain radiography for stress incontinence. Yeah, sounds like fun, doesn't it? And then horseshoe kidney is a kidney where we've got the lower poles are fused together. So instead of the kidneys being tilted inward, they're tilted outward a little bit. So the urine actually has to climb the hill to come, you know, out into the ureter. And with horseshoe kidney, sometimes you can see where they're connected, but being over the spine sometimes is kind of difficult. But the patients have a harder time with kidney stones. You know, chances are more people will have kidney stones if the orientation of the kidneys weren't the way they were. If they were sitting in there like that, chances are more people will have kidney stones. A patient with horseshoe kidney, there's still two kidneys, but they're joined at the bottom, two collecting systems, you know, so they're just tilted away, and they have a harder time with kidney stones than what do people who have separate unattached kidneys. All right, enlarged prostate just displaces the contrast in the bladder. Tomography we don't do anymore. Retrograde urography we talked about. Cystography we talked about. Voiding cystourethrogram we talked about. Axial bladder we talked about. All right, so you can see in the axial we've got separation between the anterior pelvic bones and the bladder. I think I said 30-degree oblique in the bladder, so it starts at 40 to 60 degree oblique. So you can see where the insertion is on the posterior inferior portion of the bladder. Hypertrophy, hypotrophy, and hypertrophy. All right, so you got one small kidney, hypotrophy, and then as a result, you got one big kidney as hypertrophy. Did you say hyper?
I just said it to her.
Okay, okay, all right. All right. So, any questions?